There's a variety of tools in Epic. These are workbench reports, which many of you are probably familiar with. What you may not know is that it's pretty easy to customize any of these reports so that you're able to. Is there a way to get rid of that bar up top? So that you're able to take the underlying report and kind of customize it to your own needs. Slicer Dicer is another tool that you can use pretty readily that can search by essentially any data point in Epic, whether it's an administrative code or a clinical data point. And then on a more advanced level, and then there's also a variety of more involved data tools, just like any important QI project. Sometimes it takes a few tries to get it right. Okay, a couple other projects that we went through, and maybe because for the sake of time, I'll kind of go through these. VAD survival, you can look at maybe more discrete data points, such as the acuity of the patient. So this is something that took a little programming to enter a data point, intermax category into Epic. But once that's there, you can track that data very readily. Okay, so we're going to go over a couple of projects within the Department of Surgery. We're going to start with Dr. Tran talking about how linkage between Epic and REDCap can be created so that you can collect the data you want as part of your clinical practice. And then Dr. Kling will talk about the QI Scholars Program to develop a new method to identify a data point that wasn't already present in Epic to identify postoperative complications. And then we'll finish with Dr. Cheng talking about current M&M and QI processes in the Department of Surgery.
So what we're going to do today is just talk a little bit about the vascular registry. So the motivation for that. So in the historically what we did was that anytime we wanted to look at any kind of QI project, any kind of clinical outcome studies, such as how are ruptured AAA treated at the University of Washington, usually what it started with is an email to all the faculty and say, well, can you send us a list of all the cases that you've done? And traditionally, the resident can't recognize anymore because I don't think you guys do it this way. But, when I even do it to this day, I have a notebook for basically every year that I operated. And every year I put a sticker in the notebook and then I put a diagnosis of procedure and who I did it with. And that's how I keep track of my cases. And so what I would do then, or if, with the project span for 4 years, I would take out 4 notebooks. I would sit there dutifully at my desk. I would write out all the medical record number, and I would send it to the person who was asking the question. That individual would then do a chart review and then put everything into an Excel spreadsheet. And I kind of cut this off at basically CH, but it kind of goes on even further and further with numerous number of rows. And so that's how we would basically keep track of clinical outcome, QI projects, so on and so forth. For vascular surgery, we are also part of a VQI, which is a vascular quality initiative, including multiple regions within the countries. And we do keep track of our outcome. And if you look at on the right-hand side, this is sort of a typical spreadsheet of what some of the data element that we keep track of. So obviously all these drop-down menu has to be filled in. Somebody has to do it, right? You have to pay an abstractor, a resident, a fellow, whoever it is, but it's a lot of manual labor that is needed, even though a lot of the data is already available in Epic, like Dr. Powell has mentioned. So the existing workflow is that we have REDCap, which can create a database, but then in order to have that database, someone have to manually enter in the data from a MRN. There's division-specific database, such as out of the trauma registry, so on and so forth. But then again, with all of those methods, you have to have someone manually entering the data. And as such, there could be a lot of human errors involved because if you can imagine entering multiple data points for even a single patient or multiple patients over the years, and you look at it, if you can have someone who abstracted, say, for example, a summer scholar that is a medical student, someone who's interested in doing research, and you ask them to review a chart and they're looking at that. I mean, they don't know what to do, right? Because there's multiple item there that is very hard to classify. And because of that, that's how we kind of arrive at the motivation for our vascular registries. So the thing that we wanted to do was essentially to identify and track all clinical activities within the division of vascular surgery. At the same time, we don't want to increase the workflow that is required of either our trainees or our faculty. We want to be able to use it for clinical research, for outcome, as well as QA and QI and QA projects. We want everything to be automated, meaning that it's part of the clinical workflow. So anything that you do on a daily basis should be automated. So things that we do, such as the clinic note, the consult note, the brief op note. Any patient that we come into contact with on a clinical basis, so anytime that there is a note that's created for a patient, it gets tracks. The other thing that we also want to do too was to force, or not force, but to encourage the use of drop-down menus so that the type of data that we collected, as well as the term of the data we collected, is structured, meaning that if you ask for a post exam, there's only 5 choices, either no pulse, 1, 2, or 1 to 2 plus, or not able to be examined because the patient has an amputation, for example. So the project was initially initialized in basically the beginning of 2022. So the design took about 2 months. Epic validation. So subsequent to that, we had to validate to make sure that the data that we wanted from Epic can be collected correctly, and as well as been able to be exported out of Epic. And then we had to go through committees, because as we were doing this, we had to create quote unquote new clinical node, new consult node, new operative nodes. And anytime you want to add something into Epic, you have to get approval from the clinical compliance committee, from the Epic committees, from other committees. There's a lot of them. But anyway, through all that stuff. So basically, this is sort of the general workflow. So any patient that we see, either a new patient or consult patient, clinic patients, we created a clinic note as well as a brief op note that was created. Everything is dumped into the vascular registry that was created, kind of like behind the scene in Epic. And then the Epic essentially flow into RedCap, which is a SQL, basically it's a database that is created with all the field that we kind of set up ahead of time. And through all this stuff, we're able to collect all the data that we wanted to. Everything is done automated behind the scenes. So, and I'll kind of go through the process and show you guys that. And essentially at the end of the day, we would be able to collect all the data without having to have someone manually enter it. And this is our registry in RedCap right here. Sorry, the mouse has disappeared again. You know what? There we go. And so this is how it kind of works out. So our resident, our trainee, anybody, an attending who see a patient, say in the emergency department, in clinic, on the ward, they essentially would have the vascular surgery consult note, for example. It would list the type of consult that we're seeing. So acute limb ischemia, chronic limb ischemia, et cetera, et cetera. It's a drop-down menu. So all you have to do is just click that. This is part of your normal workflow, right? You have to do this anyway as part of your clinical activities. And our trainee would go through the note. They would essentially click all these items that need to be clicked anyway. And these discrete data element that has been created, has been mapped, will go into this database. And the database is actually real, it's live. It gets updated every night, and it kept collecting data over and over and over and over on a daily basis. So as I mentioned, we started collecting data back in 2022, and the first data we collected was on 10/25/2022, and we've been collecting data ever since then. So what we have now, and when we last looked at, these are the type of consult that we have. So these are specific patients that we have that we've been collecting, along with all the data associated with patients, such as their comorbidities, their prior surgical records, their vascular exam, anything that we normally have in our clinic note, we would collect it there. So if anybody wants to go back and ask, for example, I want to see all the trauma patients that was admitted since October 2022 with X vascular exam, such as they have weak pulse, they have normal pulse, they have an ABI between certain values. You can just basically go into thread cap and collect it. And all this essentially happened behind the scenes. So what have we learned or as we go through this process? So the most difficult part was to create these discrete data element that we're collecting, right? So these data element has to match the clinical workflow. Not only does it have to do that, it has to be unique term within Epic that hasn't, number one, either been used before, it has been used before, then we have to adapt it because when we look back, for example, the post-exam, there was a post-exam data element within Epic already, but it wasn't termed as to how we as vascular surgeon would want to classify it. So we have to kind of redefine those terms. The note that we created are essentially the same type of note that we are using, but they're considered new notes, so that we have to kind of adapt it to the existing Epic structure and frame, and then compliance. So anytime you add anything into Epic, we require a lot of meetings with different committees to get it approved. And the problem with that is that some Epic committee only meets a certain number of times per year. In addition to that, Epic only get updated every, I don't know, usually 2 to 3 times a year. So even after you get through all these committees, you have to wait until the next Epic update before they can kind of implement it in your note, but it can all be done. So the future directions, how do we want to do this? So for example, now, just as in the example that I mentioned, we can still do this, but at this time, it requires someone to kind of write a little bit of a program, like in a programming code to get that. But what the next step would be to use basically language modeling engine, which they are trying to work with now, to be able to do that by just simple typing, such as how you would ask Siri something, and then in the background, that engine will kind of translate what you're asking into actual programming code to kind of pull it off our registry. We want to be able to interface our registry into the radiology database and Epic, because that's a separate database with all the imaging studies. And in addition to that, to abstract certain findings from the radiology records that we do not currently have now, because we don't have control over that, so we can't really map those. And how to handle duplicate record. Right now, every time a patient is encountered, it gets dumped to the registry is able to recognize, for example, a patient present with chronic limb ischemia, and then later, a year or 2 years later, present with another problem. They're able to recognize and able to merge them together. But the problem is that sometimes some of those servers are duplicate. For example, if they have diabetes, right? Because you have 2 discrete record with 2 discrete data, and it said the patient had diabetes time 2. So we want to be able to kind of merge it as one, and how to add additional data element to existing records. So maybe 2 to 3 years from now, we may want to look at something else that we initially didn't collect at the initial consult encounter. Can we go back and just collect those because we have those somewhere else in Epic? So all the work that are done couldn't be possible without a donation from a generous patients that we have. So I just want to recognize and acknowledge the Figueroa family, who does a lot of the donation to support the work that was able to be done for this project, as well as Nick and Patrick. They're both with ITHS. Well, Nick's no longer because he's moved on, who kind of helped me kind of conceptually realize some of the idea that I have, because I had the idea, but I couldn't really have the technical expertise to implement it, and they were able to help me with that. And that is the end.
Good morning, everyone. Thanks for the opportunity to present today. Dr. Powell asked me to talk about my experience with the QI Scholars Program, which I did about a year and a bit ago. So I wanted to start with this quote, which is that everyone in healthcare has 2 jobs when they come to work: to do their work and to improve it. And this is the essence of quality improvement. So the QI Scholars Program is a 12 months advanced training program in quality improvement, and it's really based around a project that you do. When you submit your application or interest in the program, you have to submit your project, and it can be on a spectrum. So some people really start with a newly formed idea. Other people start the program with things fairly far along, but before the implementations process. And it requires going to having lectures 1 day a month. It's about a 5% FTE. And during that 1 day a month, You hear a lecture from an expert on whatever quality improvement topic is going on. You do work on your project, and what you're learning that day is immediately applied to the project work you are doing. You present at work in progress sessions and get feedback and give feedback to your peers. You're assigned a research mentor who has experience doing quality improvement work, and the program gives you statistical support and some EPIC support. There's an additional some financial support that it comes from the department or the division as well. So this is a QI framework and how you might think through a QI problem that you have. So recognizing risk, clarifying the problem, identifying opportunities, designing solutions, implementing change, assessing the impact, and then learning and sharing. And I find that I do a lot of this, and I think surgeons do a lot of this. I think transplanters do a lot of this. You see a problem and you immediately know what the solution is and how to fix it. And this actually has a name in the QI world called problem solution reflex. I think a lot of us suffer from this. And so part of what the program helps you do is to really take a step back and spend actually the vast majority of your time on the first four steps in identifying the problem, really thinking through what the problem is, not just a problem is, identifying all the stakeholders, thinking through the potential solutions and the different impacts they may have on different stakeholders, thinking about how to engage people in the work you're doing, and then trying out small changes and finally implementing a change and tracking the outcomes. So for me, it was like, just get on with the work, but really the important part is spending time in the planning process and actually less in the implementation. These are the topics that we had my year. They change this a little bit every year. And like I mentioned earlier, as you go through these lectures, you'll be taking what you're learning in lecture that day and immediately applying it to the project work that you're doing. Some of them may not be particularly relevant to your topic that you're studying right now, but you then have a good structure to think about how to use these tools later if you come back with another project. So my project was on how to identify and automate identification of biliary strictures after liver transplant. And this happened at a time where a lot of things were sort of coalescing all at once. One, we realized that we were not doing this well. We really didn't have a good way to track biliary strictures. It used to be that we identified folks with biliary tract disease through an H-cup diagnosis, which both figured out that we had folks who got transplanted for biliary tract disease and had biliary complications after transplant. And then somebody would go in and sort of try and sort out which category they fell in. And we started out with a specificity around 23%. Along that same time, Dr. Hirose came, who has a focus on quality improvement, and we also got a new quality manager in transplant. And then in the big sort of world of transplant quality, the American College of Surgeons has decided to invest in developing a transplant QI program, TransQuip, that we are going to be part of. And so that would require data collection. And then also at the same time, we got this new transplant quality program called XinQuapi. So I worked on first my SMART aim and sort of did some data diving to see where we were, and then thought about different contributors to biliary complications, created a driver diagram, spent a lot of time in process mapping, thinking about how to identify folks in EPIC who've had a transplant, who've had biliary complications, and how you do that through either imaging or orders or labs. And then built a first EPIC report, and this was with the help of some of the EPIC folks. I don't have enough knowledge to do this by myself, but I knew how to think about what I wanted. And so we were able to identify post-liver transplant patients who'd had an order for an ERCP, and that got us pretty far along the track. But then we had a lot of folks who had had an ERCP either before transplant or ERCP without a stent. And so we really had to narrow it down over time to find folks who had an ERCP with a stent placed in their bile duct. And it was lots of iterations. And so then each of these columns is a different report validating. And then finally, we could export it to XinQuapi. And so now on a monthly basis, we get all our reports about how many biliary strictures we have. And so we can now take this structure and use it to do other things. We're seeing maybe a spike in arterial issues right now after liver transplant. And so we can take this same framework and apply it to IR angiograms and think about, how many people are having IR angiograms with stents placed in their artery. And so it's just a nice framework as we go forward in thinking about joining Transquip and building out our XynQAPI database to really identify these patients. So, thank you.
So before I get into the slides, I do want to acknowledge that the current database was created by Dr. Rebecca Main, implemented at Harborview, and then in 2022 we're able to also use it at Montlake and Northwest. My slides also include incredible work by Dr. Nina Clark. She has shared her slides with me. She's published on our database, and so those are the two highlights for the aims of my talk. But historically, I think surgical departments around the world have dual roles. There are the cornerstone, of course, quality improvement, as we talked about, but the specific timely opportunity for medical education, especially in this very specific urgent clinical context that we're all under. And so despite the use of morbidity and mortality conference, it is a challenge to talk about adverse events. Sometimes they're incompletely characterized, as we've already touched upon. And there's a seesaw between all the things that go into talking about opportunities for patient safety advancement, changes, self-recognition, as well as medical education. And so I just really want to, again, talk about that. In the early 1900s, this is a slide by Dr. Nina Clark, it was basically suggested to have these morbidity and mortality conferences at MGH. And since then, it's been incorporated by the American College of Surgeons for standardization, and then, of course, taken up by ACGME. But despite long history of trying to increase educational value, we don't have true standardization. I mean, we all can probably remember that every single experience of M&M for me might have been different for what it is here at this institution. And so it's a big difficulty to have that conference to evaluate how does it make an impact on education, especially for trainees, for faculty, and those aspects. And so here at this institution, we've really tried to use multiple strategies to address some of these standardizations. One is a name change to move away from the name of morbidity and mortality to really focus on patient safety, quality advancement, improvement. In addition, strategies are faculty reviewing the cases with residents, really getting that feedback immediately, talking about the case for a very direct focus on what's the educational value of that case. And again, really kind of trying to get away from some of the challenges for the second victim aspect of these things, but really focusing on that opportunity. And so our conference with the new database implemented, what's great is that in the past, not in the past, but as alluded previously, often much of these cases are just recorded on paper and they're not really accessible. In addition, the hospital uses an NSQIP NHSN that has abstractors. We don't get results back for 6 months, a year out. This database has immediate capture. We can immediately look at that, which I'll point out in the slides. It tries to simplify reporting. It really gives us an opportunity to even identify and provide trainees what their involvement is in regards to that. And you can't see the bottom, but ultimately it's to be strategic and again, timeliness and understanding the objectives of feedback for education. So screenshots of the REDCap database. And so there are 4 specific categories I just want to point out. Of course, demographics of the patient, procedures. We can add multiple procedures. So if patients are going back for multiple washouts, we will have 3, 4, 5 operations captured. Complications, I will have another slide going into some of the details. And then the last one is filled out the qualitative data where we capture what's discussed at the conference. And so this is, I think, one of the best parts of this database is that we can actually show ACGME what trainees are involved, who are presenting, what cases are they involved. Trainees can look back and say, you know what, I've kind of recognized that I might have had this particular area that I would like to understand in regards to the cases that I've been involved in. And so we have that opportunity to show the medical education to conferences that we all participate in. And other examples are as you can tell, with general surgery, we have quite a variety of different procedures. We're trying to capture endoscopy versus thoracic versus laparotomies, laparoscopic, robotic. And if you dial down to something as specific as hernias, we can even dial down to the types of hernias are all captured in this database. Complications, here is a bar graph. Multiple ways to look at it with REDCap, but this is a pie graph, again, showing what are discussed in our conferences. We discuss multiple types of complications, but we can really, again, look at that in regards to many QI projects. And if you think about like readmissions, what are the leading reasons that we've identified as readmissions? A screenshot or cropped of some of the database. We do have, of course, some of the difficulty with this is not automated with Epic, and that's why I appreciate Dr. Powell and all of us trying to come together, breaking down the silos between each of our different divisions in regards to quality efforts. So yes, this is a little bit cumbersome, of course, but part of that is that education. You know, what are the questions that someone might ask of me? If I do have a readmission, would I have ever thought about what were the reasons that could have led to that readmission or other complications? And again, big recognition to Dr. Nina Clark, Dr. Denzel Wood, Dr. Lauren Makubi, Lisa McIntyre, Rebecca May, myself. She has been recognized specifically for an outstanding contribution. This is not her illustration, but she made the cover. This particular paper was not just published, but also recognized by this paper, where she's made an image for the front of the journal because of what she's done with the REDCap database at Harborview. And so to share her slides and work, they looked at, of course, many of the very most likely complications: death, readmission, unplanned return to the operating room, surgical site infection, venous thrombosis, looking at the details, as I mentioned, captured by REDCap. And what this paper really looked at was, is there a concordance in regards to how trainees view complications to how faculty do? And in summary, most of us agree what the concordance of QCS are for these cases, but there is some discordance. Most of the time, we agree. Sometimes trainees think that the QCS might be a little bit higher, but rarely do trainees think it's lower. And so I think that's part of the medical education that we have to come together and bring. So overall, you know, as we've talked about, we've come a long way from writing down in our notebooks and papers. I still have stickers, of course. I think no surgeon can't live without our stickers, I believe. But we go from, you know, writing this down in a notebook somewhere to trying to use AI, but we don't want to get lost on too much automation. I think it's important for us to self-reflect and kind of see what we are contributing and think about our own contributions when we are going through training. And so overall, I just wanted to highlight some of the wonderful work by residents and opportunities for quality, and thank you for your time today. I cannot, sorry, plug in. Dr. Clark has presented at the Washington, Oregon chapter, her presentation, so I felt it made sense. But this is a local conference that we share with Washington, Oregon. I happen to be the chapter president this year. It's in September. It's just really fantastic opportunity for us to do projects like this and for us to really be involved with our local American College of Surgery chapter. There are open positions for counselors. If any faculty are interested in whatsoever being involved, very wonderful group. We work with all the surgeons across the state, Cadillac, Spokane, the Oregon chapter is highly involved. Please, 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 please email me if you have any interest in being a part of this chapter. It's a wonderful opportunity to grow some of the relationships we have, not only within our institution, with other institutions, Seattle, Washington State, and of course, Oregon. So thank you so much.
Yeah, come for questions. Yeah. You guys mind coming up here? We'll. Yep. Well, thank you very much for those presentations. I've been working with you guys for over a year and I'm still learning new stuff from what you're doing. So I appreciate that very much. So Judy, if I can maybe start with you, the manual data entry that you have in REDCap to keep track of all of the cases, do you have a sense of the fidelity of the data or how much of the cases you're actually capturing?
With regards to fidelity, no, we have not performed any validation. My own personal experience is that it is not as good because often there are so many different data points that I think that we always capture sort of just the reoperation instead of potentially apply or
The way that you develop in your notes, and your consult notes and clinic notes, because you develop those specific drop-down menus, were those drop-down menus reflective of categories in VQI? Did you use VQI to then say, these are the templated notes so that we can capture the elements correctly into VQI? Did you do that backwards work in terms of how you created the templated notes?
Yes and no. As I mentioned in the very beginning, what we wanted to do is not to change the clinical workflow. Because I think any additional step to that will lead to data fatigue, right? Because there's a point where whoever's filling the notes has to fill the notes. They're going to go through as quickly as they can, put whatever they need to do to get through so that they can put aside. And sometimes with DQI, there are so many data elements that sometimes are not relevant to what we do in the day-to-day basis, not reflect the clinical workflow. So we did look at it with it adapted, but we also still adapted what we need to do to take care of patients. So, we have to take care of patients, obviously, such as physical exams is important. So that is where that's VQI has to be done. Some of the other stuff, such as, for example, VQI track whether the patient had COVID or that's not relevant to what we do. We can also go back and look at it. So all I have to do, if I wanted to look at our database and who we've been taking care of, I can just ask Epic, look at REDCap. These are the actual encounter that we have. Does anyone in this encounter has a positive COVID test? I can go back and do that. I don't have to do that.
So a follow-up question, because does that mean that there still needs to be manual data abstraction to complete the rest of your entries for PQI?
Yes and no, because all those data abstraction, the additional data that is needed for PQI can be abstracted automatically from Epic because we have those records already. We just have to go back and ask to pull it.
And I'll just add a comment that one of the things that is occurring at the American College of Surgeons, who host most of our quality programs, is a investment in AI to help automate the data entry to minimize the cost at each center of the manual data extraction that we've all been used to doing. A step above the notebook, but a step far away from what you've accomplished with a very automated aspect of getting data elements accomplished without requiring a manual entry. So there's an effort underway, a multi-million-dollar investment to try to make our American College of Surgeons quality programs moving forward to simplify and to decrease the work effort and the cost.
All right, we have one from the Zoom chat here from Dr. Wright. I've tried a couple of times to interface with ITHS to build a registry from Epic to REDCap, but haven't had success in getting a project started. Can you give us a sense of the budget required, who we should talk to with to get started?
So when we started this, I was lucky enough to run into Nick because at the time he was doing his PhD in IT informatics. So he was very interested in doing the same thing. And we just did it basically as sort of a side project on an hourly basis. I actually don't know the actual cost because I usually, whatever time you move, people bill our division directly. I can certainly get Andy that number from our administrator, but I don't know the actual cost. From the timeline, like I said, it started from January, basically got completed by September and October. But we didn't meet every week, we meet every few weeks, and there's a lot of correspondence done by email and stuff are done without meeting. We have a full meeting, and they also have just met some work looking at Epic, looking at how the data get translated, and to speak to what Jay said a little about fidelity. We can track all this stuff. I know exactly the number of time that a data element is not incorporated to our database. So from the 3,000 something patient who has in 2022, there are 92% of them that have full vascular exam. There's 8% of them where it's part of the vascular exam is not done. We can keep track of that real time.
So we're working on that as well for the whole Department of Surgery with ITHS, and there's an hourly fee. I think a lot of that kind of got sidetracked for a few months with the budget issues that ITHS is facing. So we actually put one of their analysts on an FTE for the Department of Surgery. And so they're creating this linkage that Nam described for the Department of Surgery. And so we should probably be able to incorporate what Andy's talking about a little bit more easily. And this person now works for us. So to be able to expand it would be a lot more easy. I also think that the work that Nam did with this person, Nick, who nobody seems to be able to find, but his work was present in ITHS. So with that project code that Nam has, they were able to essentially reverse that Epic REDCap linkage, recreate it a lot faster than it took Nam to do.
I think some insight just from our project in regards to your question about fidelity. We compared to the trauma registry just to do a subgroup kind of analysis of how many complications we were actually capturing in the REDCap that we manually do. And I think Dr. Chen kind of mentioned this, but we tend to miss things like, urinary tract infections, pneumonia in ICU, line infections, smaller things that we don't necessarily even bring to QAQI conference. And so I think that for our project and for our purposes of trying to have a really comprehensive data set was a huge challenge because we weren't capturing every misfoot complication. And I think it also kind of brings up a good point about developing these databases. Dr. Tran, you mentioned having both a high fidelity and a, not letting people pre-text in fields, I think is so critical. And this is something that we learned actively when we were working with the data that came out of REDCap, was that there was so much pretext that it was incredibly difficult to code with. And so as we build these things, I think using drop downs, using kind of automatic text so that you can actually code with the data once you have it collected, makes these so much more useful for projects. And then I guess just for trainees, like this was this dumb little project that we spent, no money on to do the MLS stuff. Like I was the statistician on it. And it's gotten to the cover of a journal and like 3 national conferences. So people are apparently interested in this stuff. And we barely did any work to get it done. It was really a descriptive project, purely a data set. So.
Catherine, can you speak a minute about the amount of time it would take you to create a report like you did for the biliary complications? If you were starting de novo or somebody in this room said, I want to look at something that is not currently coded in Epic.
Yeah, so I think the biggest hurdle there is access to an Epic. In Transplant, we have some Epic people who are in-house and they're way more readily accessible than people. So, this happened just last week where just anybody out in the parking lot says, I'm doing all these arterial interventions. But then I run my own report for technicality code these, sometimes after into your liver, sometimes they do into your mesentery, sometimes they do IR embolization. And so I get a little backward, but probably took me an hour to kind of look through some of the patients I've known who had complications and then figure out what we needed to find. And then I sent that to Al Epic and Nelson, and within a day, he got me a report. Again, this report is a rudimentary report, it's not ready to export, but it if you would then wanted to then build a tech export to Zimbabwe, we would have to narrow it down to capture those who have placements or angioplasty, and that's sort of another step that I don't think that's to. That's then going back and forth with the outside and then exporting to Zimbabwe. So if that's something that we're going to keep building out, it would probably take me a couple of months. The biggest limitation is access to it.
Yeah, I wanted to ask a question, Dr. Kling, because you completed the QI Scholars Program, you talked about it here, but I think it's also a great opportunity to maybe say, help people understand if you're interested, what's the process for applying to the QI Scholars, having done it, is something you would recommend to other faculty to participate in, because I think it's an opportunity that exists within our system that you now have experience with. But what would you recommend?
Yeah, I think for me, sort of just starting my interest in QI was a really good starting point. It's not going to be a hugely comprehensive program that gives you all the solutions, but it gives you exposure enough and access to the right. Also, that then if you did want to do the health economic analysis, you have a relationship with that person that children will be done. The process for applying is the applications are due at the end of June 27th. You submit an application with a code, so you have to have an ID. It doesn't have to be a very well-formed, like partially down the pathway ID, but you have to have something that you want to work on. And that actually goes to like, if you get accepted in the program, it's approved at the hospital level. So the hospital says this is something that we are interested in, that we want to invest in to develop. It was a little bit hard to put aside the day and month because it wasn't always a certain day, Mondays and then Tuesday. And so like working this schedule was, that part was actually pretty difficult. And then, it's not just the time, the 1 day a month, it's work on a project in between that. So it's more than 5% FTE for your time. You get a lot of FTE, 5% FTE, but it's really a lot of grounds. It's on the ground doing the work, working with people. So I think if you're very experienced in QI, it's probably not the right program for you. If you have an interest in QI and need help launching, it's a great program and great foundation to start.
Yeah, thanks. It's a great session. One thing I was going to say about this project and what we've done, and I give kudos to NAMUS, it's already been done, but, so much of our time was spent, and the trainees know this, is in data acquisition. It's getting the records, it's getting all the stuff. So I said to Dan, we need an easy button, and, having an engineering mind, I think he, kind of took it and ran with it. But the one thing to remember is that these things take patience. You have to be patient with this because it's kind of like an investment fund. You started, now we're about 3 years into it, so we can start looking at it. But, you want to look at it right away and, you have not that many records, but now 3 years into it. So for all the trainees, this is an opportunity to go back and look, do some research too and identify patterns. And not just QI projects, but other things that you can identify on treatment modalities and everything else, because these records are there. The next step is linking with imaging, as Dr. Tran said, because you can get the images then too, that would make it really easy, but too much time is spent on data acquisition. And I think that with the department interest in this too, this will be great for all of our trainees in the department.
Yeah, we've been spending some time over the last year to create a larger version of the vascular interface. And so Judy and Catherine have spent a lot of time developing these essentially drop-down lists so that a brief op note will then populate the REDCap database. So we'll have a denominator of all cases. And then I think the next level to enter complications, something short of a web crawler or AI device to identify those, is a SQL search web survey that would kind of reduce the amount of effort it takes to report a complication. I think anytime you have to go do multiple steps, anything more than writing on a post-it, it becomes hard. And I think people forget to do it or don't do it. So I think the two big goals in the short term were to capture all of the cases into the database. Then you can always add data fields later and then reduce the burden of entering complications. Work in progress.